This is a video podcast with Dr. Anthony Lombardi.
Hey, everybody.
And a little treat today in TMJ, assessment and treatment, right? You're going to go over a little bit of that?
Yes, I'm going to go over, I'm just going to center myself here. I'm going to go over the basics of what you need to know without getting in depth to the assessment and treatment of TMJ, and also kind of as to preclude with what this webinar is coming up, not this Sunday, but next Sunday, March 4th, what's going to be all about. And it's going to be a great one because it's really going to be looking at a functional standpoint of how to treat and, more importantly, assess TMJ, because TMJ in general is treated very symptomatically, much like we shouldn't treat other joints. For instance, the way not to treat a shoulder pain is to, put the needles or manipulate or do the soft tissue right at the site of pain.
Right.
We want to assess and treat functionally in order to get great clinical results. And TMJ is one of the joints where they do exact opposite most people, because for the most part, they're just treating either the TMJ joint, they're putting the needle in there in the joint, or they're needling the masseter muscle, and nobody really knows anything else to do, including dentists.
Right.
So it's actually quite interesting. I'm just going to center myself here. So one second here.
And I just want to, while you do that, I'll just remind everybody to go ahead and please post your questions, comments, and anything else in the comment section of this live feed. So what I want to do is go over the webinar outline, so people really understand what it is, how this is different, and how this is really, really going to help them. Mm-hmm. And the other exciting thing about this webinar is because some of the things that are going to be taught are going to be intraoral treatment of the extremely important muscles, which in some states won't be legal, but in many places will be.
Right, and I actually was having a conversation with acupuncturist with Eileen today, and I was asking her that, and I know that too, because there are other outside of acupuncturists, say physiotherapists, where that's not permitted. But anyway, for the most part, most people can do it. Most health professionals can do it.
Right.
And where I was going with that is, part of that is going to be teaching the students, and the people that take the webinar, how to improve their tactile senses in their hands. And this is kind of a prequel to what's coming, because a lot of people are asking and talking about the manual work. And we can't, here's the thing, is we can't just put on a manual therapy course if you haven't actually worked on improving the tactile senses in your hands. It's like, it's like signing up for Mr. Universe and never working out. Mm-hmm, mm-hmm. It really, and I'm going to go over.
Which I did, and I recommend against doing it. Pretty embarrassing, actually. But yeah, you get to feel cool for a minute.
Get to meet Arnold Schwarzenegger.
Yeah, that's really what it was all about. And I didn't fool him for a second, though. But whatever. Short career, really short. So you were saying, the tactile. You got to have the tactile and know what you're looking for and what you're trying to feel, right?
Exactly. And even myself, I use my hands every day. I will do exercises before I start. I'll use. I guess you must be familiar with harmony balls, mm-hmm. Right? I use though. I have a set right here. I have different sets of those that I use. I don't know if you guys can see, right? And I'll use them to improve the tactile movement of my hands. Make sure the balls don't touch as I do this. Let me see. I don't know if we can do this. Mm-hmm. Yeah, and I work up to that, because if you don't develop your tactile senses, you'd be essentially palpating with hands of stone, and you won't feel anything. Especially when we're dealing with the TMJ, obviously you're going to be using a sanitary glove, a plastic glove, hypoallergenic glove, to go into the intraorally. So it's going to be difficult enough to feel through a glove. Mm-hmm.
So a lot of the palpation is done internally. You said intraorally. It's not necessarily on the outside.
No, no. When we assess TMJ, we're looking for two things. We're looking in general with respect to the temporomandibular joint. One, range of movement, and range of movement would be essentially opening and closing, so depression and elevation of the mandible, so the lower jawbone, and uh, um, lateral deviation. And you are listening for an audible click, but audible clicks mean nothing essentially because some people have audible clicks and never have any discomfort at all. Dentists, for the most part, will look for audible clicks, and they'll look for malocclusions where the teeth don't line up. Um, Essentially, all of my TMJ patients come from dentists. I have four local dentists that continually refer me the TMJ patients because if they improve the bite, meaning if there's an asymmetry in the bite itself, or if the patient grinds their teeth, also called bruxism, then they can fit a night guard, and that sometimes will take the pressure off the TMJ and help them. But if they've exhausted that, then they're stuck. They have no other options.
What are the most common things you see in the clinic? TMJ disorders, conditions.
The most common findings, is that what you mean?
Complaints, conditions that people come in for with their, because there are probably more than just a couple common ones, but there are probably more, no?
Yes. So pain, of course, pain with biting down, okay, and pain with opening their mouth. So it's usually pain, and it's usually either pain with biting or pain with opening. And usually they can't open as wide as the range of motion is limited, and many times they go years and they don't even know it.
Right, yeah. Or just there aren't any options for them. I mean, we had friends growing up who, they always said they could never open their mouth more than, you couldn't even put two knuckles in.
Yeah, yeah. No, I mean, a lot of times as well, and we'll go over this in the webinar, but with the history is important. Asking them, what their history of trauma is, playing sports, fights in the schoolyard, boxing, whatever their sport is, because trauma to the head and the face, especially the face itself, can actually cause muscles to become inhibited. And we have a couple of studies. I'm going to demonstrate that. And if you get hit, let's say even in the nose, for example, the medial pterygoid muscle attached at the lateral pterygoid plate, which essentially is in behind. So we know that when a muscle undergoes trauma, let's say it's the quadricep muscle or the glute, if a hockey player gets body checked into the boards, the serratus anterior shuts off. So why wouldn't one of the the muscles of the skull, of the jaw, shut off as well? Inhibition is universal. And so this over time compounds, and there's no way they're going to know it because they'll adapt over time of, chewing, eating, speaking. They adapt until they can't adapt and they have pain.
Do you find that, do you tend to use motor points a lot or cutaneous electroacupuncture or both? Is there one technique you use over another?
So I don't really use cutaneous points. It's more so motor points. So we're talking motor points of the masseter muscle, the lateral pterygoid, the temporalis, the levator scapula, the suboccipital muscles, the upper trap, and I'll be showing all those muscles. For instance, just going over the demonstration of electroacupuncture protocol, motor point demonstration of the masseter, SCM, levator scapula, temporalis, lateral pterygoid muscle.
Do you want to send that outline? We'll put it in the post in the comment section of this.
Yep.
Of this feed.
Definitely. Yeah. Let's see here. The main things, I'll do it as I'm talking here. Let's see here. Here it is. The other thing is that really people don't understand clinically is that it really comes down to four muscles. The four muscles of mastication, which are, let me see, copy. All right, and where should I send it? Oh,
That doesn't matter. You can send it to.
can I send it to your messenger? Because I'm actually on my laptop.
Yeah, send it to Messenger if you could, and
All right, there it is.
I'll pop it in here.
This is just something that has the whole thing. So the four muscles of mastication are the key players here. So masseter, everyone knows, okay, bite down, and they bite down, and they feel the masseter underneath their fingers. But that's just three of the four players. The other three are the temporalis muscle, which of course is on the side of the temporal bone, but it attaches. If I can, I'm just going to grab my skull model.
Anthony, you sent that to me in Messenger? In Facebook Messenger? Anthony?
Yes.
You sent me that in Facebook Messenger?
Yes.
Oh, there it goes. Now it popped up. Okay. There it is. My neck. I just got to stretch it out a little bit.
So the other, if you can see that, okay, the really interesting thing is what people forget is, as we said, we talked about the masseter, but then we talk about the temporalis. The temporalis is along the temporal region, but what's super, super important is that the temporalis attaches right here, the superior condyle of the mandible. Mm-hmm. So this plays a huge role. If this muscle is inhibited, if it's tight, then this inhibits or limits the opening of the jaw because it's such a big muscle. Look at the span of the temporalis muscle, and it's pulling up on the jaw. Now we can access this two ways. One, of course, we can needle the motor point, which we'll demonstrate at the webinar. Secondly, we can get this intraorally. We can release the tension of it intraorally, and very easy to do. And once we do it, it's a whole new world for these patients with TMJ. And then the other two are the lateral pterygoid, which we can access anteriorly through the face, and the medial pterygoid, which we access intraorally, which attaches to the inside part of the mandible. See, this guy's jaw is a little bit loose here. It's got a bit of TMJ going.
There's a little deviation there, doesn't it?
Yeah. Let's see where may or may not be ideal, but
he went out drinking last night and got in a fight.
So we know the masseter attaches on the outside part of the mandible, and what happens is the medial pterygoid actually. I'm just going to take his jaw off. Well, this guy's just wanting to look over his jaw. All right.
So you can access the temporalis through intraorally?
Yes. This attachment point.
And okay. Now, a couple things that I've noticed, like people that clench their jaw and grind their teeth, obviously they can have problems too. I find that the temporalis is really nasty with clenching, and then the grinding is a lot with the masseter, where you actually get that more stronger.
It's true. Yeah, it's true. And it really is, they work together because they're supplied by the same nerve, which we talk about, the trigeminal nerve. And that's the two major nerves essentially in the face are the trigeminal nerve and the facial nerve. Mm-hmm. And another thing we are going to be going over, if you look down the outline, lecture and demonstration of relationship outline the TMJ to the upper cervical spine, specifically how to needle and electrically stimulate the trigeminal nerve and the facial nerve. Go
Yeah,
ahead.
somebody asked actually if you will cover trigeminal neuralgia.
Yes, I will. Yep.
Okay.
That's in the did I add that? It's in here. Let's see. Yes, that's part of it.
I have another question here, Anthony. How often do you find a neck or cervical pathology involved in TMJ disorders?
You always have a cervical involvement. If you remember a couple of months back, I had the patient who really had a dramatic involvement where when they were opening their mouth, they were not moving because when we elevate, when we open our mouth, there is some cervical extension. Like you don't just do this. It's, and you lean back.
Hmm.
That's natural. And so that's the relationship between CO and C1, the base of the skull and the first cervical vertebrae. And and there's a lot of research demonstrating that, which we will go over. So you technically always see it, but you don't always see it as the main problem. Like for instance, with this patient, that's the first thing I addressed. I did that. If you remember, I worked on that area. I I used the traditional point. It was a GB20 right in the suboccipital triangle. Released that, did some manual work, and then went did the levator scapula. That's why that's important because we want to get as much movement as possible in that area. So you see that a lot, and that's why what I'm teaching is the main muscles of the four muscles of mastication, but then also a muscle which we touched upon in the last webinar, the platysma. The
Hmm.
platysma, which essentially attaches to the underside of the mandible and comes down and covers all of the muscles of the neck, because the platysma is the antagonistic opposite to all of the muscles of mastication. So all the muscles responsible for chewing, that is the muscle which opposes the movement. So in this patient with the cervical spine uh, issue, there was no extension to cervical spine. She actually had pain. She said, I have pain coming down my throat, the area down through here. Now, of course, I used a cutaneous nerve to help normalize the pain she was feeling, but that was the platysma muscle that wasn't firing.
Hmm.
And with that, remember, it's such a thin muscle, there isn't an accessible motor point specifically for the platysma. But there's different things that we can do. Excuse me. So really what it comes down to is, one, how do we improve the range of movement? The first thing I try to do is improve the range of movement of the TMJ, because you have a patient that comes in that if they can't bite down, they also can't open their mouth all the way, even though biting down may be their chief complaint.
Right.
So we want to get them, we want to make them believers. We want to show them in the first visit, and this happens in the first visit, that, wow, I can open my mouth so much more.
Hmm.
Wow, I don't have pain. It's like a whole new world. And then on subsequent visits, 2, 3, 4, we're working on everything else. Because you'll also find that they probably have a history, or they have upper trapezius tightness, maybe even an underlying shoulder problem. And it's like a domino effect of things. And
Mhm.
especially if they have a
Mhm.
job where they're sitting, which most people
Mhm.
have seated jobs.
Mhm. Absolutely.
Hmm. So this also does have soft tissue work involved.
The,
That's a big part of it.
it's a big part, but it's an easy part,
Hmm.
if
Hmm.
that makes sense. It takes a minute or two. It's not difficult. You're using one finger,
Hmm.
because you're just getting in there, and there's two areas that you're working. One is essentially you're releasing the lateral pterygoid and the temporalis muscle, and the other one you're releasing the medial pterygoid, and you're releasing that off of the inside part of the mandible. And it really is it's actually it really is, it's a difficult thing to treat, but this
Hmm.
approach makes it so easy. Because here's the thing, a lot of people, I'm going to say, even and the therapists that I know, the chiropractors, physios, very few go intraorally. And this is regardless of their scope of practice. They just don't. They just say,
Right.
okay, let's put some needles here. Let's do some ultrasound. Let's massage. Let's, okay, come back. You're not fixing the problem. And if you do by some prayer get resolution, it's going to take a long time.
So which pterygoid can you needle, and how do you access that?
That's the lateral pterygoid, and you access it right off the zygoma.
Mm-hmm.
So this I call the angle of the zygoma. See how it comes around here? Mm-hmm. And here's the zygomatic arch. So it's right at the point where the zygoma becomes the zygomatic arch, and I just drop off. And of course, I'm needling that way.
Up and in.
Mm-hmm. Well, I said it's perpendicular. I'm not sure what this.
It's like almost SI 18, huh? Small intestine 18. Mm-hmm. Small intestine 18 is like right around here.
Mm-hmm. Yeah, that's exactly it. So small intestine 18. I mean, it's region specific. So
right.
Call it
more or less perpendicular, or do you go up a little bit?
No, perpendicular. Yeah, you don't start going up unless you're needling around the see this space here. So this is the supracondylar notch.
Yeah.
Where the temporalis attaches to. That's the condyle that goes into the TMJ. This is the arch, the zygomatic arch. So if I'm going to try to do this straight, this notch to needle the trigeminal nerve, the trigeminal trunk, that's kind of up and in. And it really is easy, how I show it. I go through all the landmarks. Of course, I'll draw it out again on the patient. If you remember last time I was drawing it out with markers.
Oh, that's right. Yeah.
Where they are. And
there will be live demos here. That's a big...
There'll be live demos. Yeah, they'll all be on real patients. And I'm actually recruiting now. I have some patients. I have patients, real TMJ patients, that all have seen for the first time. And of course, what I'm doing is I'm vetting them, right? Because I want to make sure I'm getting patients that'll work within our timeline and won't be like, absolutely, crazy. Essentially,
it's not easy. It's not easy.
No. I want to make sure that this is how we're going to do it. I'm going to, so I'm going to actually have them come in earlier and take their history. So during it, they're not trying, chewing up our time.
Sure. Yep.
But what's great about this is they're going to get a great treatment, and it's going to be great for the viewers. And I have a good pool to choose from. I've reached out to the dentist and whatnot, and actually put some things out on Facebook. And so we're going to have probably 3 demos.
Three live awesome. Demonstrations. That is awesome. And your last one, you actually drew on the patients, which people like.
Yes, and that's what I'll do again. I'll draw on them with dry erase marker, obviously.
How does that come off? Does that come off? I saw the one patient had it all.
And they went home after. Yeah. So how does it know? It just comes off. You get it'll come off with a paper towel and water, or in the shower.
Mm-hmm. Those patients, the patients must be like, "Oh God, what's Dr. Lombardi got for me today?"
Yeah, I don't know. I just draw it. I'm not in charge of washing it off. I'm just drawing it up.
You don't even help them wash it off.
Well, I had to go to the next patient. We're running a webinar here. They know that.
They're like, "Oh, does he have a webinar this week? Maybe I'll skip."
Yeah, no, it's really helpful because it helps us visualize what the anatomy looks like.
Actually, they're coming in on a Sunday too, which is nice when you think about it. Yeah,
I compensate them. I make sure to get them some massage gift certificates and things, because they're really helping all of us out, and to make sure that they're well compensated and they enjoy it. They do.
And I got to get that Q&A out from the last webinar we had. Like 120 questions.
Yeah, one of the questions there, and I didn't address, but I did see it. They asked about what bow tie I was wearing, and it because Valentine's Day was coming up. It was a red velvet bow tie. That velvet? They were correct.
Oh, I didn't even notice it was velvet.
Yeah. So
Robert Natch says the body illustration helped so much.
Yeah.
So that was good. Any recommendation on what can be reviewed? muscular anatomy wise before?
Well, everyone is going to get the outline. So essentially following the outline, they could just go through their anatomy book or any online resources to go through everything on there. And then, of course, I'll be sending the research, the papers to go over, which we will cover in the Q&A part as well. And basically, essentially, part of it will, again, helping improve the tactile senses is really something that I'll touch upon that in the webinar. But it's this, I think as well, it will make you a better needler as a technician if you develop the tactile senses in your hands, because you can feel outside of the TMJ, you can feel where you have tight bands. So if you're doing an inline technique, if you're doing a 2-needle technique, you can feel the changes in the tissue if you're palpating cutaneous nerve. Our hands are our best resources, our best diagnostic tools. So,
what about self-treatment? Self-treatment with the...
Yes. So I give this to patients to go home. Now, there's the one video on YouTube that, I mean, as a chiropractor, as a health professional, I'm not Taylor Swift or anything, but this video went up 2 years ago and it has 340,000 views, which is about approximately 14,000 a month for the last 2 years. So that's
you
kind
went
of
viral. You actually went viral there.
Like I said, it's not like.
Did you have your dodgeball outfit on? Or what brought it?
I didn't. You don't even see my face. You just see my hands and the patient. It's 5 minutes how to treat it, and I do an intraoral release. And I do simply, I put the master motor point, and I just another one just in the TMJ, because at 5 minutes just to show them how it works. And the majority of the respondents are people, actual people. I just got a comment today, and I posted it somewhere that said, "Hey, I just tried this, and thank you. It's fixed my problem."
Really? So these are just like average, like I don't say average, but non-professional,
regular people
that aren't in the field. That's awesome. And then that video's up on your YouTube, or?
Yeah, it's on YouTube. I can even send that to you. There are 338. And that's on there, and this is kind of a snippet of, I'll send it to you, and then you can put it in the comments or whatnot. But they'll say, and then you have the majority, most of the time I have people asking me, what they should do. And I say, listen, you need to get assessed. Where do you live? Where can I send, where do you live? I'll recommend someone in your area. And then if I know someone, oftentimes they're from parts of the world where, they'd have to, maybe the Middle East or, parts where there just isn't any access that I know of. But
we have a question.
Yes.
Yeah. So Anthony, we have a question here. Somebody wants to know how often you see the scalings involved with TMJ dysfunction, and if so, will you be demonstrating how to needle the scalings?
I never see involvement, and honestly, I'm not looking for them because they're such small muscles. They definitely would be involved. They would be tight, but they wouldn't be a major player in rectifying the problem. So I won't be covering it in this webinar, but I think the time is more judiciously spent on other tissues, outside of the scaling. Unless there's concomitant cervical problem, then you would, let's say that, for instance, an auto accident. So there's a time, if they had whiplash, you could have TMJ involvement and you could have scaling involvement because they may have a radicular pain down the arm. Then you would address it, but you'd have to pick something first. If you're going to treat the radicular pain in the neck or the TMJ, then you would prioritize. But typically it's not part of the formula.
Okay, I'm trying to get this link up onto.
And the other nerve that I'm going to demonstrate is the facial nerve. And a lot of times people don't think of the facial nerve as part of the TMJ, but the outside of the trigeminal nerve, which innervates the muscles of mastication, the facial nerve does everything else. And in terms of a motor function of the face. So a lot of times, why I like to talk about it, because sometimes people think they have the trigeminal nerve because they see facial movement, and they also see movement of the buccinator muscle, or they'll see this, and they'll think, oh, that's near the jaw, I have the trigeminal nerve, and they don't. So I want to show the difference. And the other thing too is that if I show you the difference, then you can use that facial nerve point to treat Bell's palsy, which is probably not as common as TMJ, but it's pretty common. Facial nerve palsy.
Well, and people look to acupuncture for Bell's palsy because there isn't a whole lot of anything else that can help it.
No, there's nothing. There
isn't. I can't get that link to copy from my phone. Figures. So, but I'll get it up on the group afterwards. I suppose.
Or I could probably put it in the comments.
Yeah, because that's.
Well, wait, if I'll just put it in the comments on. Here.
I do that too.
Myself. Here we go.
You're in there?
Yeah, I just did it.
Yeah, I mean, I think it's going to be a great webinar. You're talking about a webinar that has demos. Mm-hmm. You have your whiteboard. You actually show real treatments with real patients that actually have the problem. So I think that's going to be awesome. Yeah. Any other questions? Let's see. I don't know. This isn't updating. Why the hell isn't updating?
I think a big one also to mention is that this is a great time with TMJ because dentists, reaching out to dentists, letting them know what you can do to help their TMJ patient, they will embrace you. It's not like other health professionals where you think, if I reach out to a family doctor, they're going to say, oh, you're a chiropractor, you're an acupuncturist, I don't understand what you do. And there might be that apprehension. However, with dentists are very approachable, especially with things that they don't have a lot of success with. Because in general, if they see a TMJ patient, what happens now, the TMJ patient comes in, they look at them and they say, okay, go here. And they send them to me. And that's so important for the dentist. You're going to laugh at why it's important, because they're busy making money. So if there's someone sitting in their chair that they can't help or they can't produce money, just get out of here so I can get someone here so I can fix. And so they will be more than happy to find that you, wherever you are the go-to person in your community to treat the TMJ. And they will welcome you with open arms.
I've had a couple more questions. Generally speaking, what's the frequency and duration of treatment of a typical TMJ disorder patient?
So frequency using acupuncture, 10 to 12 minutes.
Frequency, how often?
Oh, frequency. How often? A couple times a week for 2 weeks, tops. Yeah. Not often at all.
Pretty quick, huh? So it seems to resolve is something that you can really make a big impact with.
It's a huge impact because once you improve their range of movement, their ability to open their mouth, you improve their strength, you activate the muscles that are inhibited, and you drive down the inflammation. And unless there is a problem extraneous to the reason they're having the pain, let's say they have a fracture or something like that, which I had a patient that she slipped and fell at a supermarket and fell on her face, and she needed some reconstructive work done, and she had a hairline fracture somewhere in her skull. But in general, it's a very quick resolution.
Do you find that when people go to the dentist and have these, have a root canal or these procedures that take a long time and their mouth is stuck open, do you find that there's a lot of issues after that?
Yes. Yes.
as far as a history, as a common history.
Yes. Often, a lot of times, I see facial palsy, Bell's palsy after that procedure, but TMJ as well.
Do you use any topicals?
Not for not for TMJ. I just want to show you quickly, since you brought it up. People are probably interested, and this is just all you see is a skull. But the reason that happens, the Bell's palsy after a dental procedure. So if they have their mouth open like this, right? This is pretty reasonable. They're laying on their back, right? Okay. See this area right in here? This is where this is where the facial nerve runs down, just behind this condyle, okay? See this area? So watch what happens when they're open in a position for hours. What you get some nerve compression in there. You get some neuropraxia. And so everyone gets some neuropraxia, and most people are fine. But sometimes this neuropraxia can be for an extended period of time. And what happens shortly after, they develop Bell's palsy.
Very cool. I mean, not cool, but
well, yeah, no,
yeah.
You know, yes, they get Bell's palsy. Awesome.
These guys started
Top
to cooperate.
security.
Oh, his jaw fell off again. Can't find good help, eh?
And he was behaving himself there
He was.
for just a little bit.
Let me refresh this here.
Yeah, any other questions? It's kind of quiet tonight. Yeah, let me take this off this speaker view and put it back to gallery. That's going to be a hell of a lot better. Let's see if it does it. There's a delay. There it goes. Yeah, that gallery view is a lot better versus going on and off, back and forth. Yeah. How long is the webinar going to be? A couple hours? 2.5? What do we have?
Yes, it's going to be 2.5 hours. It'll start at 10 and it'll be finished at about 12:30. So it'll be a lot packed into the 2.5 hours, and then question and answers as well.
Well, even when you talked about the muscles that were involved, you didn't just mention these muscles, also the neck, like you said, the traps, the suboccipitals, and there's a lot to it. There's a lot involved.
There is, and we're going to teach something and demonstrate it. You want to show the whole package, and so I know the ones that many people are interested in is, of course, the major ones. But we're talking about the SCM motor points, the levator scapula, the traps that all play a role. That all have an attachment to either the cervical spine, the skull, or the jaw itself. Those are the main players of the TMJ. And assessing it, learning how to assess it, and getting some intraoral pointers, some education on that. It's a game changer. It is. I mean, I've had every person who's had TMJ that's come into my office has been successful, and it's just simply from following the basics. Because everyone else either treats it with a splint, a night guard, or treats it, externally. And it's the masseter, and you can only get so far with the masseter. You need to change the mechanics.
Someone asked is it going to be recorded? Yeah, this will be available. It'll be more though. It's 119 live, and we do encourage everybody to attend the live one because we get lots of questions, we get interaction, I don't know, it's just good. It's just a lot of fun when we have a good live turnout. So the live ones are always going to be lower in price than the recorded. So we definitely encourage you to attend the live one. The recorded one could take some time depending on how much editing has to happen before it actually becomes available. So it really depends. I don't edit it, so we have to send it out to somebody else, and that takes a lot of time. So, and again, more time, more labor, more money for us that we have to pay somebody to do it. So we charge more for the recording for those reasons as well.
And the good thing about if you're able to join it live, then you also get the recorded version.
Oh yeah, you get the live. You're going to get the recording for life. You just got to show up to the live, and then obviously all the recordings, all the recorded seminars and webinars on AccuVids are lifetime access now. So.
And Josh, I had a question from someone. If they're able to join, if they purchase the webinar and are able to join it in progress, let's say they're an hour late, they'll be able to watch the rest of the seminar and will they still get the recorded version?
Jesus, why don't you just ask me a difficult question right live?
No, I mean,
let's say it's 2.5 hours. Show up at like 2 hours late. Yeah, no problem.
No, not necessarily 2 hours late, but you know what I mean. Like,
what's the cutoff before I'm a total asshole and actually say no, you're not going to get this webinar? Screw you. I don't know. I mean, obviously things happen. Technology is a problem, right? But we haven't had that problem yet, so it's worked out well. And people want to come on and they want to get they want to watch it live and get their questions answered. If something comes up, boom, they can ask it right away.
Yeah, no, that's important.
Yeah. Quick giving people ideas, Anthony.
Well, that's a question I had.
So we do.
I was just gonna just make sure that Anthony doesn't have any more like policy questions or terms and conditions type stuff you want to go over. No, I'm sorry. Go ahead.
All right, so we do have a legitimate question here. Somebody wants to know if you do any manual stimulation on the needles, or if you just put them in and put the pointer on them.
So it depends how tight the muscles are. First of all, it also depends on the patient, right? If the patient has pacemaker or any relative or absolute contraindications to stim, then I just will stimulate it manually. Or if there has been any surgery around the TMJ, sometimes I get post-surgery patients. So I'll go into the TMJ or I'll go into the scar and I'll peck and thread underneath the scar. So there are certain times where I will use it, and it's fine, and you definitely can do that. But if there's no contraindications, your results using the electricity will be leaps and bounds ahead because of the effects that it has, the real very positive effects.
California CEUs? No, we did not get California. I mean, I don't know. I guess we could try to get California CEUs for the recording. We haven't applied for anything yet. Live webinar Sunday, March 4th. That's the links above. Somebody says, if the seminar I'm attending is boring, I'll tune in. So you could, right? I mean, you could be at the seminar, have some headphones on, and
yeah, this won't be boring. That's for sure.
Yeah, I don't suspect that the last couple of words, they're just packed with information, so you can't snooze. I don't even think I snoozed.
Yeah, and it's Eastern time. It's 10 a.m. Eastern
time, which we'll make the future ones a little bit later probably because the California people are whining. All the hippies are whining about having to get up early. Jesus.
Yeah, but at the same time, we have the people from Australia who are getting up at like 2 a.m.
Yeah, that's true. Yeah, and it's 5 hours difference to Europe in a lot of places like Ireland. So 5, 6, 7 hours. So yeah, they put them in the afternoon. Damn it, you just can't make everybody happy. What are you gonna do? Got a question?
Yeah, we had another question. Somebody just wants to confirm the dates for the live seminar.
Live seminar or webinar?
I think they mean webinar.
You mean Sunday, March 4th?
Yeah, that one.
Sunday, March 4th, 10 a.m. Eastern.
Come on, peoples. Here's your chance. Ask some questions. I think we got Rob's question. Do you spin or stim the needles? I think that's what you...
No, there's an interesting Robert Nash he mentioned, and that's a good point. Because the TMJ is a little bit more intricate, to delineate. He talks about a grease pencil, which is smart. I'm going to actually fiddle around with that because that'll help delineate the zygomatic arch and the supracondylar notch better.
A grease? What's it? A grease pencil?
Yeah, a grease pencil. It's like a pencil, but it's almost like a soft crayon. You ever seen those before?
No, so you're going to try to highlight the jawbone and use like a nice foundation and then bring it up with...
Oh, yeah, that's right. I could just get that for my wife, the makeup pencils.
She knows how to do all that.
That's what I'll do.
She could come in and be like, almost ready. Just give me 5. Okay, we can't go yet, so we got to wait. Yeah, that could really extenuate everything. No, that's not... You know what, though, Anthony? If you set that precedence, then you're going to have to really step up every webinar.
That's okay. I'm always about improving. That's for sure.
Oh, so grease pencil equals makeup pencil. Right.
Oh, okay. I didn't know that.
Grease pencil. That sounds like, hey, you want to get greasy? Here, let me put some of this on you.
Okay, I'll get
Grease
that.
Ball. Let's see. Oh, why is my voice so sultry? That will be what a few days in the hospital with the flu will do. I reckon. I'm probably rested. That's what it is.
Well, you guys do look rested.
Well, that's all we both did all weekend because we're both sick.
Matt, in between his sickness, had to stop by the hospital. You got away the one time I was sleeping.
Yeah.
Second time, though, I woke up. You were trying to sneak something in. I was like, no. I woke up. Hey, you guys are awful. Hey, that's not nice at all. Okay, so somebody says, I have the patient clench their teeth and then needle toward the back of the head over the ear. Mm-hmm. Is that gallbladder? No. Good question. I palpate, and if there's tightness, I needle there. What does that say about... Ooh, there's more. Okay, so basically, she has the patient clench their teeth and then needle toward the back of the head, so front to back, over the ear. So it's just going to be over the lateral ear. Yeah, if you bite down, you can... like around gallbladder 8 or 9, which would be above the apex of the ear, maybe about, centimeter or so.
It's like trigger point 4 in the temporalis, roughly, I think. My TCM, vague TCM points are a little off.
It might, whatever muscle that is, but again, the bigger picture would be like you'd be needling that point for a reason. Mm-hmm. Right, and that'll be based on your assessment, and you don't want to just needle it because it's tight. I know people do that, and you will get an effect, but it's not going to be, it's not going to be a tangible, reproducible effect every time. You're not going to know what you're going to get.
Because there is a trigger point around there.
Yeah. Well, trigger point 4, but so you tend to have that tends to refer pain up here in this area.
So, that would be a clinical indication, I reckon.
Yeah, I tend to use that one more for headaches.
So there's involvement in the scalp, yeah. Yep. If you so happen to not make any progress in your treatments, what would you recommend as the next step? Refer out, kill yourself, give up, quit? Which would you cry in a fetal position in the corner? That's my favorite. So if you happen to not make any progress in your troops, I guess it would depend. What would your expectations be, Anthony?
So my expectations would be that they would improve.
Immediate, like at least some improvement that first day, not curative, of course.
Yes, definitely first improvement in range of motion the first visit, for sure. Well, this goes with pretty much all my patients, not just TMJ. The first 2 visits are, we date back to when we do the XSTOR. We don't do XSTOR here, but it's the same approach. We're assessing and then we're treating. First 2 visits, I want to see a significant improvement. If I don't, And if there's, if we go 3, 4 treatments, we still don't, then I'll refer out for imaging for sure. And usually they don't have imaging yet because they've gone to their dentist, right? And they might have an X-ray, but like a panoramic X-ray, but they don't have an X-ray of the entire skull or of that vantage point, and they sure don't have an MRI. That's where I would go for. Now again, MRI, if this is just something that's 2 or 3 weeks old, then we still try to look at different aspects. But chances are, if they reach me, they've had it for a while, like 6 months or more.
So what's one example of like an assessment? Obviously, location of pain or pain depending on the movement, right, would tell you a lot.
Right. Explaining when they have the pain. They'll say it happens when I do this, when I chew, when I yawn, when I talk, and I have pain, and they might tell me where it travels. And then from there, I go through my range of motion, have them open, have them close, deviate side to side, do some muscle tests, of course, assess the cervical spine, sometimes assess the upper extremity, depending on the impact. If it was a trauma where, like, again, an auto accident, something like that, where there's more than one thing going on. And all this stuff, it can be done quickly, in a short amount of time. And then from there, we can then address. But treating anteriorly and treating the nerves, the trigeminal nerve, and then treating intraorally, you've covered all your bases. After that, if you don't have any improvements, then there's something else going on. Guaranteed there's something else going on. What? Who knows? A fracture. I had one patient who wasn't responding. She had a fracture.
Yeah, there you go. And we had Rebecca commented vodka. That's probably the most brilliant comment. Wow.
Oh, that's if the patient's not improving, drink vodka.
Oh, maybe that's what it's. Rebecca, you're really killing it tonight. You're on a roll. Got any other complicated?
Vodka's actually very healthy for
insights? And Rebecca, you should know better than to put vodka when tequila is obviously the correct drink. More often, dental offices have a cone beam CT that will give 3D images of the bony structures.
Oh, there's Robert. Yeah, he would know those. So that's see, I've been to dentists. The dentists I go to, they don't have that stuff. Maybe it's just pretty.
Robert's talking about high society, like real dentists. Yeah, okay. All right. Well, I think that's good. No other questions. I'm just watching it. I don't see any new ones coming on.
But yeah, I mean, it's I'm excited about the webinar upcoming, and yeah, it's really going to be something. The TMJ is an important part. We don't see it every day, but we do see it quite often.
Oh, it's like one of those things, as soon as if you're going to see it, you'll probably see it in 3s, 4s, or, you just start getting it. And then it doesn't hurt to try to get a referral source from
yeah, definitely approach the dentist, speak to the dentist, let them know what your skill set is and why it is you can treat TMJ better than them. And they will more than happy send them to you, because there's not a lot of money in mouth guards. In night guards, trust me. And the dentist told me this, and I said, hey, anything I can do to help, and I can help the patient, that's fantastic. And the other thing is, I was going to say something else that was pretty profound. I lost it. I don't know what that was.
Well, one of the things also with the masseter muscle is it can cause single-sided tinnitus. So it's a really good idea to know how to treat it, because you can release it with the motor points. So there could be other things involved there too, where they have TMJ, and a lot of other reasons that the muscles are good to treat. All right, I think that's it. Slackers. Thank you, everybody, for showing up and watching. We'll leave this up on the group, of course, And if you have any questions, email Matt or call his personal phone at 315. No, just email support at Chinese Medicine That Works. Or check out acuvids.com. I believe that's it. Anthony, thanks a lot.
Thanks, guys. I'm looking forward to it, and I'm glad to see you're feeling better, Josh and Matt.
Yeah, more or less. More or less. It was funny because during the whole thing, I was sick as a mofo, and during the whole thing, my stomach's growling with hunger. My stomach was pissed off the whole weekend. It was like, feed me. That's all. And I'm like, what the hell? Freaking got a fever over here, dehydrated as all hell, and my stomach's growling, you know? So I got to eat. I ate well. More tequila, says Rob. Yeah. You wait, Rob. You show up. You're going to show up to Syracuse? Yeah, we'll have a bottle for you. So, and thank you, everybody. Thanks, Ben and Deborah and Robert and everybody else for showing up. Always a good time. We're going to be back on tomorrow. Yeah, everybody. We're going to have another podcast tomorrow, and it's going to be on Lyme disease.
Oh, that's a couple people.
Yeah, we have a specialist coming on. A couple people. Brian Crawford is coming on, and Hillary Thing. Hillary is from my hometown area, New Paltz area, I believe. She practices there. Chock full of Lyme disease. So Hudson Valley, New York State. Yeah, it's pretty nasty. So we'll have Hillary on and Brian, and we'll be asking them questions on Lyme disease. So I think we have a lot of what's that? Yeah,
it'll be actually. I'm actually going to tune in for that because it'll be really interesting. Because in Canada, the diagnosis of Lyme disease is extremely controversial.
Really?
Yes, and I'm probably some Canadians who watch this will tune in and send in questions. In fact, doctors don't like to give the diagnosis of Lyme disease here in Canada. And now I'm not familiar with all the tests, but in Canada, there's several different tests, from my understanding, that can create a positive for Lyme disease. In Canada, they only do one, and if you're not positive for that, you don't have Lyme disease. And in fact, from my experience, they treat that patient almost like they alienate them. They're like, you don't have Lyme disease, you don't have it, so we're not giving any of the drugs for Lyme disease. And sure enough, they go to the United States and they or different countries, and they get different diagnoses or get different medications. And anyway, I know it works both ways, but in Canada, it's kind of like you don't want to get Lyme disease because if you don't test positive for it, then no one's going to help you.
Yeah, that's the thing, and it's different even between states in this country too. I mean, that's the thing. It's got to be frustrating as all hell. So
yeah, that's going to be a good podcast.
Yeah, it's going to be a lot of fun. I think we're gonna have a good time tomorrow, and the next week we have podcasts. We have Christian Horner Warren coming on, KHW coming on. We have Jimmy Yen coming on. We got a bunch of stuff coming up. And God knows what else we're going to fill the time with. So hopefully, everybody tunes in. Yeah. So Anthony, I guess we'll see you tomorrow night. We'll be on 8 p.m.
Definitely. I'll
Eastern time.
Question in. What time is it tomorrow? 7?
8.
8.
Yeah, 8 p.m. Eastern time, as you know, but other people might not. So, but yeah, it'll be fun.
Okay.
All right. Thanks a lot.
All right, guys. Everyone have a good night. It was always a pleasure, and we'll see you on the 4th.
You got it.
All right. Take care.
Thanks, Anthony.
Thanks, Anthony.
Bye, guys.